I'm delighted to be here, and it came about because Patsy, who I can't see now, where's she gone? Oh, there you go, has sort of foot in both the Department of Health and here, and we've been working, and the Department of Health have been really supportive about looking at new contracting methods. So I'm delighted to be able to talk about it to a different sort of audience. I'm not usually outside of my health and social care circle, so excited to be here. I'm a paediatrician by background. My consultant post was at Lewisham Hospital. Unfortunately, as you may well know, Lewisham's going through some changes at the moment. When I was there, I think in child health, compared with certainly adult services, you know, we have a reasonably good track record about working with other services, with police, with in fact youth offending, with obviously social services, housing, as well as all our other sort of clinical colleagues. But I was always aware when I was working that we're good at doing that, but the system is organised in a different way. And were there ways that we could sort of underpin that good intent for partnership working in the way we actually do business, as in buy services and contract for services? I then sort of went on my career path is very sort of odd and complicated, but through that time I kept that alive, and I'm really fortunate in that my brother works in the oil industry and he lives in Australia, so I don't see him very much, but in conversations I said, well, tell me again, how do you do that? And what they were doing in the oil industry, I thought, wow, that's something we could apply in health. So over the past 8-9 years I've thought about this a lot, and really over the last 2 years I've sort of gone out and said, no, I really want to see if we can make this work. And I'm delighted to say that it's really getting traction. It's landing at a time when integrated care, collaborative working is really kind of a hot topic in health and in social care. So what I shall do today is I will tell you about it, tell you why it excites me, what I think works, and where we've got to in the sort of health and social care side. And there'll be an opportunity, and I want to hear from you, whether you think that's applicable in your world and how it might add value. So just to start, as I say, this is something that's been around for years. We keep talking about it as a new contracting method, and it's not. It's been around for a long time, sort of coming up 20 years. And what was happening in the North Sea was a lot of platforms were going up in the 90s, and every single one of those was over budget, very late, everybody suing everybody else and counter-suing and so on. And so different oil companies were trying out different supply chain management, to use the jargon word. And one iteration of that was this thing called alliance contracting. And the first oil rig that went up in the North Sea that used alliance contracting method, which was, you know, getting people to say, we will contract with you to build this oil rig if you will work collaboratively, is the sort of bottom line for it. The results were outstanding. So at the time, I'm going to get the numbers wrong because I haven't looked at them for a while, but you know, the kind of going rate for a new oil rig was something like 450 million. When the Alliance got together, the first job they were given was, what do you think the target costs will be? And they came in at 380 million-ish or something like that. They revised that down further over the first few months of the project. When it was finally built, it came in at 285 million. So a massive reduction over the sort of normal cost. And not only that, it was completed 6 months early. And therefore BP, as it was unfortunately, who were the financiers for that, were pumping oil 6 months ahead of schedule. So the results were amazing. The caveat is that the second one that they did like this was not so successful. So it's not a magic bullet. You've got to work at it and you've got to work hard. But the kind of way of working spread to Australia with the movement of some people, including my brother, who worked on the initial project, and became a very established way. Alliance contracting became a very established way of big construction, big infrastructure projects. The first public sector one was in 1998, and there have been over 400 in the sort of Australia, New Zealand and Pacific areas. It is used in the UK. It is something that we use in construction. Terminal 5 was an alliance build. Unfortunately, they had 1, issues with costs, and 2, if you do remember the opening day of Terminal 5 that week. So unfortunately, it's not a great one to use, but it's used in defence contracts and energy and so on. So mostly in capital projects, mostly in building something, but it is used in services and is adapted for that. I'm really pleased to say that the first UK Alliance contract in health and social care has just gone live. So, and I'll tell you a little bit more about that. It's actually in mental health services, and I think there's a lot of read across to some of the work that you do. So just to take a very simple way of thinking about this, there are hundreds of different contracting methods. You know, how many parties there are, the funding flows and so on. There's hundreds of ways you can describe contracts and different ways of doing it. But just if you just think about straight service contracts through to alliances, one of the key issues about how the parties share risk. So how they share risks between themselves as providers, but also how the commissioner shares the risk with the providers as well. This is the basic concept. In a traditional contract, the commissioner will have a large pot of money and will have different providers doing different bits of what they want to happen. So even if it's across a whole system, there will be separate contracts with each party. Each of those contracts will have separate objectives, and the performance of each provider will be judged on their own performance, their specific bit. So you could have a great performance, but the whole experience, the whole system is not working well, or vice versa. And what very typically happens is that if one of those providers, say the one on the right, says, look, we're doing our job really, really well, it's those guys over there who are not doing, you know, what they're supposed to do, they're not, in my world, referring on quickly enough, etc., etc., they go to the commissioner, sort it out, go and speak to them and sort it out. So the commissioner ends up being the coordinator. In an alliance contract, the difference is that all those providers are still very important parts of the system, but they all come together to be signatories to one contract. So there's a system contract. So each of those providers maintains their own unique identity. This is not a merger, it's not an acquisition, it's not a changed format. They maintain all of their internal controls and so on, but they all end up working to one set of objectives, to one contract. There is only one performance framework, and it is how is the whole system working, and therefore success is judged just on that. Now, obviously, internally, you may do some sort of differentials about how different bits of it are working in order that you can make improvements, but that will not count in terms of the remuneration. And what that does is it means that all of those providers are now in a situation where, you know, they're all part of the same team. So it's your problem is my problem, your success is my success. If we collectively feel that there's a part of our system that's not working, we're all accountable and responsible for making sure that that improves and works, because we've all got a vested interest in that. And the whole thing is done by a lot of work up front on setting up this sort of sense of trust between all the parties, not just between the parties, but also with the commissioner. This diagram's quite simplistic in, you know, just making that comparison, but in fact the alliance actually includes the commissioner as well. And we can talk about that. And very importantly, the contract will describe the outcomes and the relationships, so the outcomes you want to get from this whole system, and how people are going to relate to each other, the providers with each other and the providers and commissioners. But it doesn't describe the what or the how. So it doesn't have a tight specification. And certainly in health, less so in social care, but in health, we like tight specifications. You know, you describe every inch of it. And that's very much what the oil sector did. You know, they would try and cover all angles, but then you get that kind of behaviour of, a contractor would say, oh, well, you know, this isn't in the contract, therefore I need to now charge you an additional cost over that. You get rid of all that because you just describe the outcomes, and it's the providers who have to come to you with saying this is how we're going to deliver it. And the whole point of that is because you actually want them to keep making it better. So for the service model, if you like, the way whatever that sort of service is delivered, at the end of a contract life, you want it to look different to the beginning because you wanted people to keep improving it. And you can't do that if you've described opening hours and this, that and the other at the beginning. So for me, an alliance contract is actually a contract for innovation as much as it is for integration and collaboration. So there's a whole kind of different techniques that they use to make this happen. None of them complicated, and they're all really, really commonsensical. And they're all things that we all try and do. And I think it's just sort of putting them all together and having not just that intent, but then some of the more technical stuff supporting it, I think really makes it work. And when I talk in a health audience, I sort of talk about these ones. So leadership, number one. So as a commissioner, you've got to sort of let go. You know, if you're not doing a tight specification and you're actually building trust, you've got to let go of some of the things you may be used to doing. As a commissioner as well, your leadership role is really to set that expectation of innovation and collaboration. And that requires, you know, not the sort of table thumping type of adversarial contract relationships we may have got used to. On the provider side, the leadership as well needs to be not just about how do I get the best out of this for my organisation. There's a bit of that, and that's fine, but there's also how do we make the whole system good. So, you know, the leadership of those organisations or teams need to stand up and have a wider brief as well. A lot of time up front is spent on alignment, and that's either during the procurement phase or, I don't know how relevant this is for yourselves, but in health and social care we have set providers, geographical ones. For instance, in a hospital there may not be some other choice, so you've got to take existing providers and get them working and thinking in a different way. And they spend a lot of time at the beginning or in procurement workshopping this sense of alignment. What do you as an organisation want to get out of this? What do you as an organisation bring to the table? What are your business drivers, and can we make sure that those are aligned with what we're trying to achieve in buying these services from you? And what I'm going to do now is I'm going to ask you to just think about that a little bit more. I mean, this is you know, I'm going to learn as much as well, because I'm not used to doing this, not in a health audience where we usually get the same sort of things. But what I'd like you to do is just think about a service that I don't know if you're commissioners or providers, would either be putting out to buy, or you as a provider would be offering your services to provide. So, okay, thank you. I'm sure you can go on, but all I want to do is just capture a sort of sense of, you know, some ideas from the floor. It's going to be very end democratic. As soon as I've got 3 or 4 that we can use, we'll stop at that point, even though you've got lots of fantastic things you want to tell me. So just shout out some examples of what you've just said. What would this fantastic probation service achieve?
Reduce reoffending, yeah.
Okay. I think even I might have worked that one out. Okay.
Prevent offending.
Rehabilitation of offenders.
Right, hang on, I've got 2. Let me.
Prevent offending. First yeah.
Prevent first time of.
Well, prevent escalation to court and getting into prison. So it may or may not have been a probation, but it's certainly a missing link. That's 12-month people and
Okay.
kids coming through.
Okay. Sorry, you were saying.
I was saying rehabilitation of offenders.
Okay. Okay. Does that mean into work, into jobs, into?
Yes.
Yeah. So can I be specific about that? Can I put offenders into work? Do you mind? Is that okay?
And to that,
Sorry.
One of the proposals that we recently heard is that we should have ex-offenders mentoring them.
Okay, that's a how, but it's really, yeah, we'll come back to that point. Okay, so I'm sure there's lots more, but is that a good enough list? Just most of you would sign up to that. Okay, what I want you to just give me a sense of, are there, if you were to do this in, I'll say Sussex, are there different organisations or are there single organisations who do this? Would you need multiple organisations? Yeah, okay, that's fine. I need to keep this short because we've kind of got to move on. What I just want you to do now is go back into those pairs and just, if you are going to achieve that, what does that really mean for you? What does that really mean for you in the role that you're going to do now? Does it mean you've got to change anything? Does it mean you've got to carry on doing what you do now? What are the sort of things that what's your personal, professional, or your business? Will doing that fit with everything that you aspire to do? And if that's, yes, 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 and yes, and yes. Think about, are there organisations who might put themselves up for doing that who don't have drivers that fit with that? Does that make sense? I mean, I think what we typically find is we say, oh yeah, we're all signed up to that. But actually, when you just start drilling down a little bit, you immediately pick up some perverse incentives or some parties who actually it might not be the best thing if we do achieve this. And then if you drill down even further into, what does this mean in terms of your, for us, it's, most things will require clinicians to act differently. Well, that's a big ask when people are feeling under pressure and so on. So even if they might want to do that and so on, the actual, what they've now got to do to change to do that kind of holds against it, and it doesn't happen, even though everybody's going, no, that's the right thing to do.
So in some areas and not others.
Yeah,
So
absolutely.
So
So this issue of having these conversations, I mean, we've just literally had 5 minutes, but you would actually, my job and the role I would do is to make people have these conversations and keep having them. Get everything on the table, and particularly the misalignments. Be honest about it. We've got examples where people all come together, some fantastic strategic partnership in health, and the chief exec signed a, a kind of memo of understanding, etc., and goes out the room, and the director of finance turns around and goes, no, over my dead body. Verbatim, I can tell you that happened. So it's about going, well, no, come back into the room, tell us why. We want to understand why that's really difficult for you, not you're just going to obstruct later down the line. So this issue of alignment and doing it before you start and doing it in real depth and getting people to get it on the table is absolutely critical. Then you can put the shared risk and incentive system. We're all going to, reward ourselves if we achieve this level and this level and this level and so on. And we're going to divvy it up. And then importantly, if you sign up to an alliance, you're signing up to a commitment to collaboration. I hate that graphic. I've taken it off since I've clearly left it on. And there are a number of elements to that. So one is that all decisions made by the alliance are best for service, not best for individual organisations. And all decisions are unanimous. And that's a sort of really interesting one. Usually people go, oh, well, that means that someone's got the right of veto. Well, no, it's not about that. It's actually about saying whatever solution and whatever, and this is for major decisions, doesn't necessarily need for small decisions, but for major decisions, if there is a party who says, actually, we really don't sign up to this, it will fall apart at some point. Night follows day. So the leadership of that alliance should say, okay, go away and come back with a different solution. And they'll come back and they'll say, oh, look, we're happy now, but so-and-so's not happy. Well, go away and come back. And this thing about you've got nowhere to hide, you've got to resolve it, and you've got to find a way through it is really critical. And that's linked to this commitment to no disputes, no fault, no blame culture. So if you put a dispute clause in a contract or a termination clause because of dispute, you've got an exit door, and people will just take it because it's easier to do that than to resolve it. And so it's a really important thing. And if it feels quite difficult, and it feels quite far from certainly in my world where we are, but it works. And what's interesting is when you talk to the people who've done many of these, they say you spend hours at the beginning talking about all the downsides and the what if this goes wrong and what if that goes wrong. You hardly ever use them. So we focus on when it all goes wrong, as opposed to actually, if you set this up right, it will go right. You would always agree a set of principles by which you're going to behave, and that would include things like the best for service, transparency, and so on. The one underneath, open book accounting, open book reporting of performance between all the parties, and so on, and other ones that particular alliance agrees. And you absolutely need a joint management structure. The idea that you can work collaboratively with a number of different providers by maybe meeting once a month at some sort of strategic level is just a non-starter. You've got to be thinking, instead of being thinking like this, you've got to think and work like that. You don't need an alliance contract in order to do that, I have to say. I mean, certainly in health and social care, we're very bad at that coordination factor. It's a particular bugbear of mine, so I better stop. So just to give you a little sense of the governance structure, this is just very typically what you would have. You'd have, obviously, the commissioner would be the owner, as the language would be in other sectors. Your alliance leadership team will be senior members, including from the Commissioner. The Commissioner is part of the leadership team, the accountable team, and the leadership team is accountable for the delivery of the service, for ensuring the delivery of the service. The important bit is that every member has got the authority to commit resources for their organisation. You cannot have the alliance leadership team agreeing a decision and then everybody going, now I've got to take it back to my board. So you knock that on the head before you start. People have to have a reasonably significant level of delegated authority. Underneath then would be your alliance management team. Ooh, key 77 people. Not quite sure how that's arrived, but the key people with subject expertise, people who do the day-to-day, kind of understanding the service and so on. And it's the alliance management team who are accountable for delivering the service to the standards expected and to meet the outcomes expected by the Commissioner. And you would always appoint an alliance manager. It doesn't have to be a full-time role if it's not a big service, it can be part-time, but you've got to have somebody who's the go-to person for doing it. There's no strict rules, so there are loads and loads of different examples I could give you. I just use this one for things like you might have an alliance leadership team that covers sort of a large geographical area and then smaller sub-alliances for different pockets within that. Or it may be, in health we might have a long-term conditions alliance leadership team. You might have your diabetes and your chronic obstructive pulmonary disease and another one's underneath it. So, you can mix and match. And also, you can also have I'll just go back to that, combinations where you have still got some subcontractors who would be kind of working within this. It doesn't have to always include absolutely everybody who's involved with that whole system. I'll just touch a couple more slides just on some of what happens then. So once you've got all that alignment, once you've got your governance set up and it's, people are kind of looking to do things differently, it's then underpinned with the kind of commercial and performance framework. And this slide tries to illustrate for you the principles of that commercial framework. So on the, I haven't tested this. Yeah. So here on the left, this is the sort of what's called the scope of work part. So all providers will get reimbursed for their direct costs for providing that service. And what counts as a direct cost would be listed in the contract. There is a pre-agreed corporate overhead and profit. Again, in health and social care, we wouldn't call it profit because it's politically difficult, but surplus or some other word. And that profit is set such that if you achieve what's on there as MCOS, minimum conditions of satisfaction, I'll come on to that in a sec, then you agree what that amount would be for each of the different providers. And this is all openly negotiated with everybody in the room. It's all up front. There's no, we're going to talk to them behind closed doors bit. It's all openly negotiated up front. What then happens is that over here, you overlay this with a reward and penalty or reward and risk share, gain share, pain share is the term that's used in other sectors. So that if on the performance metrics, which you have set to underpin your outcomes, you achieve that sort of minimum level, that's the, I can't do it this tight, that level, that's the kind of neutral point. If you perform even better than that, there's more money in it. It's a whole system incentive, so that money goes up. But conversely, if you sign up to be part of that, you also sign up that if the performance is poor against those measures that you've got in your performance framework, then that can eat into your profit and it can eat into your overheads if it's getting really poor. So that there is always an incentive to keep on delivering better and better for those for whatever your performance metrics underneath those are. Importantly, the pain, I want to point, which didn't happen. The pain share will never eat into direct costs, so no provider would lose their shirt. You don't want to be putting anybody out of business. That's not the ethos of this whole thing. So you would always make provision that people would get their direct costs covered. They just wouldn't get their the sort of cost plus part of that. And as I say, people spend a lot of time on the pain share, but actually, almost without question, you're up in the gain share area in these. So So just one more slide about the gain share, pain share. One of the techniques they use and is that any metric you would put, so like your reduced reoffending, so your reoffending rates, you wouldn't set a target, you would have a spectrum. So you would say reoffending rates 0 to 100% potentially. Obviously you'd put what your 0 point is, the sort of minimum expected. I don't know what you would expect. What's your kind of, I'm going to say, I don't know, people reoffending 30%? 38%, okay. That's now, is it, ish? Okay, thank you. So you'd put that as your 0, but then you'd put any improvement on that, which of course is now inverse, isn't it? So 20% would be better, 10% would be better. You put that, you know, you itemise that, and you actually put a money sign next to it, a pound sign. And one of the techniques that they use is this thing called gain breaking. So I don't know about yourselves, but we're used to setting a target and then a stretch target. And what they will say is just set something ridiculous. Describe what, a game breaker, more than outstanding performance. It's like nobody thinks it's even possible to achieve it. It's way out there. And of course, what happens is if, say, you've got, I don't know, let's say 4 results areas, 5 or 6 performance measures underneath each one of those. If you set up a group of people who really kind of understand, working collaboratively, thinking differently, got permission to think outside the box, they'll end up achieving 1 or 2 of those. So by setting it and by putting a number on it, and setting the expectation that people could reach that. And one of the definitions is a stretch target is something you will reach if you do what we do now really, really well. A game breaker target is something that we've got to do something completely different in order to be able to achieve that. So it's another way that they drive innovative thinking. Does that make sense? Yeah. So how do you set one up? Well, this slide has been prepared, again, thinking about health and social care, and I'd be interested in how much it sits with your world. So the first thing I always sort of stress and do is commissioner readiness. The commissioner has to be really clear on what they're doing. Have they got do they really understand what working in an alliance way means? If they're wanting to force it just because they've got a bad provider on the patch, it may well not be a good place to start. It might be really good, but actually, do they really want to work differently? They've obviously got to have an idea of what they're going to, what the scope is of the service, the system that they want to contract, and they've got to have some idea of how they're going to set what's the funding envelope and how the funding flows are going to work. But importantly, the next bit is that alignment. And as I say, if you go out to procurement, it's basically the commissioner will say, we want. I'll have to use an example from health. So we want a sort of, a diabetes service that delivers, reduced hospital admissions, people back in work. I mean, we had the sort of very similar sort of social outcomes probably, and that they've got, reduced complication rates from diabetes. And we want people to come with ideas of, how they would be part of that service, and we want it to be an alliance of people with different sorts of skill sets. So the commissioner would run that and choose the different parts of that system. And then typically you could spend 2 days just workshopping it with 1 or 2 of your preferred bidders and putting them in the room with another group who are kind of doing a different part of the pathway, test it out, how do they sit, test out what their values are, test out what the business drivers for the organisation are, do they really sit? And so you do that in a very thorough way. So you go out to procure on, are they up for collaboration? Have they got a good track record in it? Have they got great innovative ideas? You don't procure on price competition. As I say, we're often in a situation where there isn't going to be a procurement round, so you've got to get the existing providers into the right mindset and way of working. It can be more difficult, although the one we've got up and running, it was exactly that, and has been really successful. So it's about how you take people on that journey to do it. And it is only when you're sure that you've got the right partners, and this is, with the right, commitment to collaboration, then you go and finalise all the technical side, and importantly only then would you kind of really nail down what that service model implementation plan may look like. And then just the last bit is obviously sort of just launch, and don't forget to make sure all the staff in all the relevant organisations are aware of it, and so on. But that launch bit is really just the beginning of the alliance. This is just getting you to first base. So, so in health, I mean, it's landing really well. People, you know, there's certainly this feels, when I speak to people, they say, gosh, this is what we're trying to do, but we just didn't know how. And that's the kind of reaction I typically get, particularly among clinicians who want to work in partnership with other providers, but are kind of like, oh, the contract gets in the way, or whatever it may be. Not always, you know, true, but that's what people believe. Certainly with our new commissioners, the clinical commissioning groups, the GP-led commissioners, they are definitely up for doing things differently. Obviously, the sort of how you then go ahead and do it is not always as straightforward as one would like. As I said earlier, the Department of Health at NHS England, the Cooperation and Competition Panel are one of our regulators and so on. They've been very supportive and are certainly up for seeing how this might work. So the services that we're considering are frail and elderly, urgent care, mental health, long-term conditions, and I, as a paediatrician, am really keen that somebody tries this in children's services. We're not quite there yet. The mental health service one that we've got going is actually a council-led contract with 2 third sector providers for recovery and enablement for people who have had specialists, who've either been inpatients or been under specialist care. And it's for the first year, there's no risk share, so all we've done so far is just do that alignment piece, set up the governance, and we're going to baseline the kind of performance metrics, which are very outcome-based and have been designed by a group of people, frontline staff and people who use services and carers, and that will kick in year 2 of